Tetanus treatment. Okay, let's get into it. Hello, everybody. Welcome back. Like with a lot of this module, this is me kind of a quick little lecture. I'll try to highlight the things that are important for you all or for my exam. There's going to be some stuff in here that's not really testable for me, for pharmacology, but may help you with pathophys and or ICM. So we'll see. Let's get into it. Introduction here, just read through this, but basically this is a nervous system disorder. They have muscle spasms. Lockjaw is one of those that historically was associated with it, but it's from the bacteria Clostridium tetani. Anyways, just read through the rest of that. 4 clinical patterns you have to be concerned with tetanus, and here they are listed here. Pretty rare nowadays, so especially here in the U.S., you don't come across this a lot, but it still is on your board question, or it's still on the NCPA blueprint for the board exam. So still something that you guys have to study and think about. So it will still pop up on board questions, and then you never know. You maybe will work internationally, or you'll have some international patients here in the U.S. So anyways. Usually this is going to be in inpatient. So if this happens, this is going to be an inpatient setting, probably the ICU. You need specialists, et cetera, involved. But like I said, you guys are going to test it over. You never know what kind of patients you're going to see. Here are the goals of treatment, and we'll go through these a little bit more in detail here. Just go ahead and read through those. First, with halting toxin production, we need to be concerned about wound management. So this is something that needs to be, and usually they'll have protocols for wound debridement, etc. You guys will be learning more about that in other courses. Antimicrobial therapy. So they're not a big player, but they still are used and they still are prescribed. So of the ones that we want to be concerned with, metronidazole, which is Flagyl. So you're going to use that IV, 500 milligrams Q68. Is the #1 drug of choice, but for some reason, if that's not available, if the patient can't take it, intolerant or whatever, you can go with Pen-G IV. Stays of treatment there about a week long. Testing purposes for me, just know the drugs, first line, second line, but don't worry about the dosaging for my test. If there is a mixed infection, meaning so it's tetanus plus other things, or you're suspecting a kind of a grab bag of infections, you want to think about using more broad spectrum antibiotics. So that's where the first, second, or third generation cephalosporins come into play, and then we have some examples here. So know about those. An alternate agent too, again, if you have a mixed infection, is doxycycline. So that is something to think about. And then maybe some macrolides too. But that's kind of, not first line or whatever, but so mixed infection, probably first line, you want to go with cephalosporin, whichever one's on formulary at the hospital you're at. The neutralization of the unbound toxin is also important to think about. So that's something that will be part of your strategy. So go ahead and read through this. In the US, we have the tetanus immune globulin. This is the abbreviation here. Not really. Oh, H is for the human. I was like, I'm not really sure that it's human tetanus. HTIG, I guess, is what the cool kids say. I don't know. And that one can be used, and that will help with the neutralization of the unbound toxin. And there are the doses there, and the dosage administration. So tetanus is a little bit different in that you don't have immunity following the acute illness, so that all patients there, this is important here, need to be have the immunizations given. They can use the Tdap, so look at that. That's more common probably, and so you can look at that it can be used instead of just the tetanus by itself, and so you think about that. Why isn't this my computer working again? Okay, there we go. And then you guys probably heard this in other courses, maybe not, but with the tetanus, it needs to be 10-year intervals throughout adulthood. So that is something that may be relevant for your other patients as well, not patients who have an active tetanus infection or acute illness. This is just a recommendation for all of your patients. So that may be something that you're screening if, inpatient or outpatient at the clinic. Control of muscle spasms. So I mentioned the lockjaw, but this is a big problem with the tetanus disease, and they can cause respiratory failure. So it's a very severe form of muscle spasms. It's not like, oh, I get a cramp after working out or whatever kind of muscle spasms. It's a very severe type of muscle spasms. A lot of different medications can be used for them. The other thing too is just kind of non-pharmacological, that the patient's environment can have a profound effect, and so that can also help prevent spasms. So read through there and make sure you know that they need to be kind of in a calm, cool, not bright or noisy room. Benzodiazepines and other sedatives. So as far as pharmacological interventions are concerned, you remember hopefully from the previous lectures, we talked about the benzodiazepines. So specifically, diazepam is going to be your drug of choice. You can use other ones, but this is the most popular based on duration of action and its effectiveness. So that's something that you can think about as for first line treatment for the muscle spasm specifically. Here's the starting dose, and diazepam can be given IV for a quicker onset, or PO too if they they need to be on it a little bit longer. But you need to be mindful that you do need the ventilatory assistance, especially at higher doses, because the benzodiazepines can cause problems breathing. So that's something to think about. And go ahead and read through this too. This is another thing that's important to think about this is an inpatient setting, so it's not super critical, but definitely you need to be mindful of the anion gap, and that there is a potential for metabolic acidosis. If there is those problems with the metabolic acidosis, you can go to midazolam, so that would be a rationale to use that. And so that can be IV, midazolam can be a second line choice there, or again, if you're having problems with the metabolic acidosis. And then here you'll note here this last point, I talked about physical dependence in previous lectures, and so because of that, if the patient is on the benzodiazepines, which they probably will be on higher doses and longer term benzodiazepines, they do need to be tapered gradually, so they don't have withdrawal reactions. I always get questions from students about the taper schedule, so you guys can look those up. They have some suggested taper schedules, but it's not a black and white thing as far as there's just only one way to taper. So first of all, it's going to depend on which benzodiazepine you're on and its half-life and how you administer it. The other thing is going to depend on the patient too, and how much they were requiring, how high of dose they were on it, and how long they were on it. But it's basically, you just slowly decrease the dose over, a few weeks. Or a week or two, again, it kind of depends. I can't give an exact answer here, but going to depend on the medication and the patient. You can also go with propofol, which you hopefully remember from previous lectures too, but there are some issues with that. It is a much stronger medication, so it will help with the muscle spasms, but typically not the first line or the first thing you jump to, unless it's really severe or you don't have benzodiazepines, or if the patient is allergic to benzodiazepines, right? Or if they have some contraindication to benzodiazepines, then maybe propofol would be. But it does have some problems. The lactic acidosis, again, is a concern. Can increase triglycerides, and then the pancreatic dysfunction too. So has some concerns with that. With neuromuscular blocking agents, if you are just interested in sedation alone, or rather, when the sedation alone is inadequate, you can go with stronger agents to help induce the sedation. So benzodiazepines cause sedation, and they will sedate patients. But if the patient again needs additional sedation, you can go with the neuromuscular blocking agents. So we have the pancuronium and the vecuronium. But the pancuronium is what was used more historically. But it looks like the vecuronium is going to be a better choice as far as first line. It is shorter acting. and it has less adverse effects that you have to be concerned with. So that may be this will probably be your first line one here to go with. So you can put a star by that. And then definitely these patients need to be monitored, and they're going to be in an inpatient setting. Anesthesiologists are going to give you these medications. So there have been a few studies done with baclofen, which is, we're going to talk about that in the musculoskeletal module, so you haven't talked about that medication yet. I've left in the hyperlinks here for UpToDate, so if you see a drug like this and you want to just know about it now, you can go ahead and click on it, and then that should take you to UpToDate, or in LexiComp that's within like UpToDate, so you can read about the drug ahead of time if you'd like. But so that is something that is still kind of being studied, and it may be used, but not typically first line. Historically, too, the phenothiazines and the barbiturates were used, but because of adverse effects and other concerns with those medications, they're not popularly used now. At least here in the U.S., that you may still see them in other countries, or if there's some shortage or they can't get a hold of some of these other things, you may still see some of those being used. The magnesium sulfate, this is interesting, definitely read through this slide, can be used as an adjunctive treatment for controlling spasms. So that may be part of the array of drugs, part of your toolbox, so to speak, that they will use for the tetanus treatment. So, and here's some more rationale as why it is beneficial. In addition, for the autonomic dysfunction, you can go with the beta blockade, so you can go with beta blockers. So of those, labetalol is going to be your first line choice because it does have alpha and beta blocking properties, so it has a dual function. So it's very effective at managing that autonomic dysfunction. And then you should not use propranolol because unfortunately there are reports of sudden death with the use of propranolol. So the morphine too can also help. It helps with sedation. It's definitely very sedating. We'll talk about that more in the musculoskeletal module, but then it also helps some with the autonomic dysfunction. Some of the other drugs that have been used, and then maybe, but there's not a ton of research on them, are the atropine, clonidine, and bupivacaine. So those are some that you may see. Again, this is a very, very rare. I'm kind of hesitant when I'm saying a lot of this during this lecture, just because it's such a rare disease to come across out in practice, but but these are some of the drugs too you may see, and I would imagine that the infectious disease doctor would definitely be involved, and they probably would be following some kind of protocol, and then be coordinating with the hospital pharmacy to see which of these drugs do they even carry and which ones they have and everything, and what's part of their tetanus protocol. Airway management and other supportive measures. Just go ahead and read through this. This wouldn't be anything that for testing purposes for me. Obviously, I stick to the drugs, so definitely know the drugs that we've been talking about today. But just read through this, just more FYI for my course. Same thing here, just FYI. Maybe it'll be beneficial with ICM. I'm not sure. This one too. Just know that sometimes, there's a drug, sucralfate. We're going to talk about the sucralfate and then other acid blockers in the GI module. So you haven't had those yet, but basically that can help with GI or hemorrhage and stress ulcer formation. So just note that can be part of the plan. But I mean, don't worry about that too much. Actually, for this test, yeah, it's just FYI at this point. This one is interesting too, but don't stress too much about it. So you're interested in preventing thromboembolisms when patients are in the hospital, so you can go with heparin or the Lovenox or other anticoagulants. So that's something that'll be part of your strategy, and just because there can be paralysis and immobilization with these patients after they've been treated. So then the physical therapy is also going to be an important part. But this slide too, just FYI from my exam. So that's it. Thank you guys for your time and attention. You notice a lot of that's just FYI. I initially was just like, I'll just put like those 2 slides that have drugs on it. Where is it? like the antibiotics and like benzodiazepines. But then I just felt like there may be more confusion, more questions if I just randomly be like, here, benzodiazepines. And so anyway, so a lot of this stuff is just in here for like a full, complete picture. But for testing purposes, just focus on the drugs I mentioned. So benzodiazepines, other sedatives. We mentioned the neuromuscular blocking agents, and then some of the stuff for the autonomic dysfunction. Look at those too. So anyways, not a ton of stuff, but if you have any questions about it, feel free to email me. And thank you guys for your time and attention. I'll talk to you later.